Hello, and welcome back to Designing Care on Air. This is Elizabeth Johnson with Montana State University. And on today's episode, we have Dr. Margaret Hammersla from Montana State University, who will be talking with us about when we have healthcare from home and this evolving model where really we're in their turf, their environment. So how do we augment our care delivery and our workflow to meet our patients where they are, especially in rural spaces? So I want to welcome Dr. Hammersla to Designing Care on Air. Thanks for being here.
Thanks so much for having me.
So just to kick us off, just tell us a little bit about your background, your journey in nursing, and how you got interested in home-based care.
Yeah. So I started my career in nursing in long-term care. So I worked as a nurse in long-term care in a variety of roles, including at the bedside, unit manager, director of nursing, and decided I just wanted to have a broader impact. And so went back to school to become a nurse practitioner, worked in geriatric medicine and internal medicine as a nurse practitioner for a number of years. At the same time, obtained my doctoral degree and started working as faculty. And about 3 years ago, I landed at Montana State as an assistant professor and connected with Bozeman Health geriatric team, who was doing a lot of the work I was doing in a clinic setting, and they were doing it in the home. And I thought, how unique, because we have so many challenges with our frail older adults trying to get them care from a clinic. So it was really a unique opportunity to combine my ability to work as a faculty member, do research, and deliver care, and look at innovative ways we can restructure delivery models to really be advantageous to that population.
And you came to Montana during the pandemic.
I did come during the pandemic. It was a really interesting time, particularly for our frail older adults who were terrified to come into a clinic setting. We were also in a lot of the assisted livings and the nursing homes that were really devastatingly impacted, and saw some of how those impacts really changed the way patients and family members wanted to engage with the healthcare system and what we needed to do to better provide for them to keep them out of the hospital and out of the doctor's office during that time. So it was a little bit of the Wild West in Montana during that time.
It sounds like it. So for our listeners, some of which are engineers and architects, can you walk us through, when you're going into somebody's home to deliver care, what do you encounter? What are some ways that you've had to adapt yourself to working in a home environment? You close that car door, you go up to knock on the front door. How do you deliver care? How do you deliver advanced practice care in the home?
In a lot of ways, there's some really distinct advantages to delivering care in the home. Number one is when they come into the office, they're telling us what their home situation looks at through their lens rather than through a healthcare provider's lens. So there's some distinct advantages just in terms of looking at where they're living, how it's impacting their healthcare, what the setting looks like, safety issues that we need to take into consideration. So there's some advantages to doing that. I would say the barriers really are around the space that we're in and the distance we have to travel. So we are still limited in how far away from the clinic we can go. But once you get in there, you have to carry everything you need. So I have to carry a provider's exam office with me. So I have otoscopes to look in people's ears. I have ophthalmoscopes to look in their eyes. I have a fully equipped bag to do blood draws. I have my stethoscope, my blood pressure cuff. So there's a lot of equipment that we carry in. And so it's heavy, and I've actually been switching it up to try to make it a little bit more efficient lately. The other thing that's been really interesting is homes are different. They're not designed for where they are. And we deal with a lot of really frail elderly that are bedbound or can't move around easily, and the spaces are tight. So I'm drawing blood, and I'm doing it in really non-ergonomic ways. I'm bending over. I'm trying to reach across a bed because they're not in a hospital bed. They're just laying in the middle of their king-size bed at home. And so finding ways to adapt to that has been a little bit of a challenge. But I would say overall, the benefits outweigh the challenges. But there are just physical limitations to what we can do.
So have you seen caregivers or patients actually augment the space to fit you at all? Or is it really more the accommodations on your end?
A little bit of both. Some people are able to make those accommodations. We certainly have family members that will do that their loved one has rented a hospital bed, or they have a wheelchair, or they've created space. They've really set up the room as more of a assisted living type space. But there are also people who either don't, mainly because they want it to still be their space. They don't want it to look like a hospital space. They want it to feel like their home, and they don't want to adjust it. Or they just simply don't have the resources to make any adjustments, and they're literally doing the best that they can.
And of course, this is a really unique subset to be able to go into the home. It's not like you can come out of school and know automatically how to really work with these communities and their patients. What type of training or additional education or experiences did you feel helped you to be able to be perceptive to the environment that you were going into?
I think there's two pieces to that. One is when you're going into the home and you're doing this work, these patients are very medically complex. So there's just a certain level of experience that you need because you really are out there kind of on your own, and you don't have that kind of armchair consult from your colleague in the next room over. So from an experiential standpoint, I think that's for the medical. In terms of being able to look at what's going on in the home and evaluate that, I think that my time in long-term care was a huge benefit because I had to help people function in their home because it was their home. And I dealt with people who had physical limitations in addition to their medical problems. So I have a sense from doing that work and discharging people into the home and being able to understand what those needs are and challenges. So I think actually my time in long-term care was one of my, probably didn't appreciate it at the time, but somewhere where I really learned about caring for elders and the uniqueness of kind of what they needed beyond just medication prescriptions.
Which is really interesting, right? Because I feel like there's some sort of taboo to long-term care. Working skilled nursing, immediately coming out of school. Everybody thinks of going straight to the hospital.
It's not sexy.
It's not really, right? Bed, Bath, and Beyond, if you will.
That's right.
And so we hear that sometimes all the time, and it's not right. So it seems like you were able to get that systems level perspective because it required this holistic.
It's funny you say that. I remember after about 6 months of working in long-term care telling my husband, okay, I went to school to be a nurse, but I'm functioning as the mechanic, I'm functioning as the design person for rooms, I'm functioning as the social worker, I'm functioning as the nurse manager, I'm functioning as a business manager because I'm managing a lot of things. So yeah, I would say long-term care really does give you a systems level perspective into how healthcare is delivered, as opposed to going and working on a med-surg unit where you're going to get really good at that, but you're not going to have as much understanding about what happens to your patients outside of your unique floor, both within the hospital, on discharge at home, and in a primary care office, where in long-term care, you really did get a much larger view of system.
And when we even go deeper into rural culture, right, it's looking at resources and these insider versus outsider and networks of care. So how do you find a network? How do you find colleagues to consult with? How do you really establish yourself in that type of community-based care?
So I think here I've been really fortunate working with the Bozeman Health geriatric team because Bozeman Health has been embedded in the Gallatin Valley for an extensive amount of time. They're well respected in the area, and they do have a cultural history of what's going on, as long as you're kind of close enough to town and there's resources available. I think where it really gets to be a bigger challenge is when you get a little bit farther out. It really is true that those people fit more into the frontier than rural. I've been focused on saying frontier because rural does not even begin to describe what we see once we get 15 miles outside of the Bozeman area. There's really frontier. People are embedded in their community in a way that we don't see closer to town. And there really is a sense of we care for our own. So I think meeting people where they are and understanding where they've been pulling from their resources, looking at the community centers, their church, like what are those things, and trying to build and figure out how we can keep them in that community. Because once they move out of that community, they become disconnected really quickly and impacts their quality of life. And I certainly don't have the answers yet, but I am working really hard to try to figure it out.
And I really like the idea of embeddedness. And that's something that we look at in design is actually giving back agency and control in your environment through design of space to make it work for everybody involved, to give back that agency. So if you kind of go back to the idea of embeddedness, that this is their environment, this is their home, you're coming in, but you're also working in that environment. What are some changes that you may see in design that would really help facilitate care, that would also help their embeddedness and maintain those relationships in the community, but also give us a footing up, and where healthcare is going, which is more towards the home setting?
I think the first thing is to respect what's important to the person in that space. I think that coming in and saying we're going to completely redesign this space to make it work for you in a way that we want it to work for you is not helpful, because they're going to close the door and they're not even going to engage with you anymore. I think the first step is to ask what's important about this space. How do you need to live in this space? Then have a conversation around how those limitations are creating barriers to doing those things. What's important? And honoring that, honoring the fact that this space is important and that I can't redesign the important things out just because it would work better. I need to think about new and innovative ways. And I certainly don't have that, but I appreciate the architects who look at space and do that. But what I will say with the frail elders is the design elements aren't as important. The color of the walls, the modernness of it, and those probably aren't the right words because I'm not an architect, but I think honoring what they want it to look like and what's important to them, if we don't start there, we're not going to make any progress.
So really beginning with meaningful design in mind, right? Like what's the nucleus here?
Yeah. And again, what's important to them? Because if what's important to them is that their grandkids have access, then we need to make sure their grandkids still have access. If what's important is I have slept in this bed with my husband for the last 50 years and I know he's gone, but I'm not leaving this bed, we need to find a way to make that bed work in that space. Those kind of things are important, and we don't often know unless we ask first.
And I think that's the biggest part, right? Is ask the question. Don't be afraid to ask the question.
Yeah, don't come in with answers. Come in with questions.
I love that. And to kind of wrap up, I think that's a great way to kind of end this is, what pieces of advice would you have for these groups that are really looking at, we've heard about disruptors in home health care. We've got all these new groups even coming into Montana that are looking to really augment how we're doing community-based care. What advice and words of advice do you have for our students as well as those groups looking to get into rural healthcare?
Number one, and my daughter worked with a home builder, and I loved the idea that they thought about needs in the home when they were originally designing homes. So I would love for our communities that are builders that are building communities to understand that this is an aging population, put some infrastructure in homes to accommodate that at the beginning rather than waiting till there's problems. But more so in terms of kind of how we go into these communities and make it work. I think that asking the questions is certainly important. Then recognizing that every community is a little bit different and thinking about approaching the person with questions such as, what are you hoping for over the next 5 to 10 years? How is it you want to spend that time? How are you creating your own quality living during whatever time you have left? And how can we help you achieve that rather than telling them all the things they can't do?
So really looking at agency and empowerment.
In their definition of it.
Exactly.
And honoring that. I've had a few patients that have said, I can't even talk. They came in and told us she had to go to the nursing home and they won't let me visit in the hospital and they won't let me visit in the nursing home. So I'm not going there. And they think because I don't have a college education, I'm not smart enough to take care of her. And I am. So I just went home and did it. And because we gave them that message, we weren't able to provide assistance, and mistakes were made that he wouldn't have if we would have helped him recognize what those options were in a way he understood, because he was more than happy to deliver that care.
And that's where design, it can be a great equalizer. We don't have to speak at a high level. It doesn't have to be, like you said, something modern or replicative of inpatient. It can be just the smallest adaptable things, having the light work a little better so that person can read.
Having something that adapts their own bed that they've been sleeping in for 50 years rather than telling them they need a new bed.
Or don't move the quilt at the end of the bed.
Don't move the quilt at the end of the bed.
I think we both have learned that one.
Make sure there's room for my kitty cat.
Yes, exactly. Well, Margaret, thank you so much for being on Design Care on Air. We appreciate your time. And for our readers, our listeners, something to keep in mind is that the latest USDA report noted that we actually had a migration of older adults into rural space at the highest level seen ever.
Mm-hmm.
And this trend is not going away. We've started to see the aging of these rural populations. So what Margaret's talking about is not just a one-off phenomenon that we're going to be seeing. It's not isolated to small towns, but it's actually a phenomenon that we're seeing across the region and ultimately will be seen across the United States. So when we're thinking about design, it's really across the lifespan and outside of hospital doors. This is Elizabeth Johnson for Designing Care on Air. We'll see you next time.